Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric. This week, we are again joined by Jason Jarvis, who is a former Special Forces medic with a master's degree from the London School of Tropical Medicine and Hygiene, and is now finishing his PhD in Tropical Medicine and Education. Jason, welcome back to the program.
Thanks, Aebhric. It's good to be back.
So tell us a bit about yourself and what's keeping you busy.
What's keeping me busy currently is I'm enrolled in a PhD program for health professions education over at Widener University here in the States. They're over in Chester, Pennsylvania. I, on the other hand, am in Seattle. So I'm doing this, so far, the entire program at a distance, which is very conducive to my geographic location and my work, which is primarily teaching American Heart Association, ACLs, and PALS throughout the Seattle area here.
And you will be coming to Malta for the MIM conference.
Yes, I will be there at the end of January for that, and then staying on for a couple of weeks to help out with a couple of the quorum short courses.
Are you speaking at the conference this year?
I don't think so, but if there's an invitation, I might be persuaded to do so.
Every quarter, we try to do a special episode on tropical diseases. So, Jason, what are we talking about this time?
So what we're talking about this session is Chagas disease, which is also known as American trypanosomiasis. And this is a parasitic disease that has predominantly thrived in Central and South America. However, the endemic range of the insect vector has shifted northward. So we are now seeing locally transmitted cases of Chagas disease in the southern United States.
So there are bugs that are passing this Chagas disease in the U.S. by fecal matter.
Yeah, essentially that is the case. So we'll get into that with the life cycle of the organism, and we'll talk about what's up with the bug stool with the transmission of this particular parasite. So the bug itself is commonly referred to as the kissing bug, or the assassin bug, or the triatomine bug. It goes by a few different colloquial names. Species-wise, the top two on the list here are the Triatoma infestans and the Rhodnius prolixus. So these bugs, if people that listening are familiar with stink bugs, they look very similar to those. So they're about 2.5 centimeters long, or so, about an inch long. And you can think of these as almost like overgrown bed bugs in their sort of habits and the way that they feed on people. So these kissing bugs will sit in the cracks and crevices of your bedroom, right? And at night, as the occupants of the room are sleeping, the bugs come out and basically gravitate towards the warm body that's laying there. That's the person. And they'll crawl onto that person, and they're looking for a blood meal. These are non-flying insects, by the way, so they don't have wings that work. So they crawl onto the patient or the person there, and they prefer really, really thin skin. So if you think about where the thinnest skin is on your body, it's typically right around the eyes, right? You have very thin skin there. So the bugs will come up there and they'll bite the person on the face or right around the eye and take the blood meal. And that's why they're called kissing bugs, because they prefer the face bites where the skin is thinner and it's easier for them to access a blood meal. So once the kissing bug has finished its blood meal on the person's face, they have a tendency to defecate on site, and then they crawl back to their cracks and crevices in the walls and hide out once again. So within the stool of the infected kissing bug is the organism, is the parasitic organism that we're talking about today. So the organism is called Trypanosoma cruzi, and this is a trypanosome organism that's similar to the trypanosomes that are found in Africa. And what's interesting is over on the African side of the ocean, the trypanosomiasis is vectored by tsetse flies, the Glossina morsitans flies. And in this case, the the organism is transmitted via the blood meal directly. So very similar to your mosquito-borne viral diseases, so your arboviruses or malaria, where the organism or the parasite is introduced into the host via the blood meal. So you have a similar organism, similar parasite in Africa. So African trypanosomiasis over on that side. And the appearance of the parasite in the blood, which we'll get to, is nearly identical to the trypanosome that we see on the American side with Trypanosoma cruzi or Chagas disease. So let's get into what the parasite is. So Trypanosoma cruzi is a protozoal disease. So it's a protozoal organism. And probably the simplest way to think of a protozoa is just think of a bacteria cell that's very large and complex, and in some cases has a sexual replication cycle as well as an asexual replication cycle. In the case of Trypanosoma cruzi, there is only an asexual replication cycle. So these reproduce only by binary fission, similar to bacteria. So within the stool of the kissing bug, you have the organism, and at this stage, the parasite is known as a metacyclic trypomastogote. And we're going to see the name of the organism change as it goes through the various stages of the life cycle in a similar manner as malaria. So malaria, you have several different stages of that parasite, and we have different names for the different stages there. So the metacyclic trypomastogotes are shed onto the skin of the patient in the stool next to the bite wound that the insect vector has just created. The metacyclic trypomastogotes make their way through the bite wound into the host tissue. So once the parasite has gone into the body, it's going to go ahead and it's going to invade the local cells. So right at the bite wound, basically. It's going to go into the cells, so it becomes an intracellular parasite at that point. And once the metacyclic trypomastogotes enter the cells, they shed their tails, or they shed their flagella, and they become amastogotes. So they are now non-flagellated parasites at that point. Just taking a step back, there's essentially 4 different types of protozoal parasites, and these each they're classified by how they move. So the classification for Trypanosoma cruzi is it is a mastigophora parasite, which means it has a tail or a flagella that it uses to move around. And there are several mastigophora protozoa that infect humans. So listeners will surely have heard of things like Giardia. So that's one of the mastigophora, Giardia lamblia or Giardia intestinalis. You also have Trichomonas vaginalis. So that's another flagellated protozoa or mammals. You have the African trypanosomiasis and you have leishmaniasis. So these are all very well-known flagellated protozoa that infect people. So the 3 other types, which we won't dwell too long here. The 3 other types of protozoa, you have the Sarcodina, which are the amoeboid protozoa. So the most important one in that classification is Entamoeba histolytica, which causes amoebic dysentery, which is very common in East and Southeast Asia. You have the Apicomplexa protozoa, which includes malaria as well as toxoplasmosis and cryptosporidium. So that's a very important group. And then the 4th category of protozoa are the ciliated protozoa. These are called Ciliophora. And the only one that's really of importance medically there is Balantidium coli. So back to the life cycle here. We had the kissing bug take a blood meal on the face or near the eye of the person. The stool is passed onto the skin. The metacyclic trypomastogote penetrates the skin wound, enters the nearby cells, loses its tail, and is now known as an amastogote. So within the local cells, the amastogotes begin feeding on the cells from within. They are also replicating via binary fission. So they're basically just dividing into sort of like our cells do for the most part. And what you see at this stage of the infection, this would be known as the acute phase of the infection. And then later on, we'll see the chronic phase setting in, where we get into some of the cardiac issues and whatnot. So what we see in this first acute phase, following the 1 to 2 week incubation period, what we see is inflammation at the site of the bite. And if the insect has bitten the patient near the eye, which is where they usually go, then you get this inflammation around one eye, which is very characteristic of this infection, and that's called a chagoma, or also known as Romagna sign, if you see that. Okay, so once the amastigotes within the local cells at the bite site have reproduced sufficiently, they'll start releasing their offspring into the bloodstream. And once they're in the bloodstream, they will now have flagella. So they now have tails again, and in the bloodstream they're known as trypomastigotes. And in the acute phase of this infection, before the host immune system has recognized that there has been an invasion, you will see the trypomastigotes in blood smears. So we could do a thick or thin smear blood test, stain it, and look at it under microscopy, just like we would for malaria. And the trypomastigotes are extracellular, so they're not in the red blood cells as we would see in malaria or babesiosis. So these are going to be extracellular, and they have a very characteristic look. They sort of look like a flag waving, if you can envision that. The patient, in the meantime, will exhibit things like fever, malaise, so sort of flu-like symptoms. They'll typically have a skin rash. They may have, in severe cases, myocarditis and possibly angioencephalitis at this stage. And so we see this in like the first couple months following the 1 to 2 week incubation period. And again, we have what we call patent parasitemia. So if you do a blood smear, you will probably see the parasite under microscopy.
One thing that I found interesting when I was doing microscopy at London School and Liverpool School of Tropical Medicine is the Chagas is huge compared to a red blood cell. So when you do a blood smear, these trypanosomes are gigantic. And what's interesting was the Chagas, the trypanosome of the Chagas disease, is often a C shape as well. And this is how I studied for the exam, was if I see a trypanosome that's characteristically a C shape, and yes, one side of it is kind of flapping in the breeze, so it looks like a flag, but the C shape of the trypanosome means the C in Chagas.
I love a good mnemonic. That's how I've gotten this far in medicine. So continuing with the life cycle. So once the host immune system has recognized that there's been an invasion of the Trypanosoma cruzi organism, then the parasite sort of goes to ground. So you don't see it in the blood any longer. So now the disease would be considered no longer patent, where you can readily see it on X microscopy under oil immersion. So the organism goes to ground in the form of infected cells, where you have amastigotes that sort of dormant for years to decades. And now at this point, the patient has entered the chronic stage of the disease. So the disease is now subpatent. Right? So in a subpatent infection, we can't just see organisms any longer on visual microscopy. The best way to detect the infection at this point is to look for IgG antibodies in the blood. And this chronic phase runs to sort of fulmination over a 5 to 40 year span of time. And then what we see at the chronic stage is we're seeing some really, really bad things. So we're seeing things like dilated myopathy. So we're seeing in the heart will get large. So we'll have in the large heart that often comes with atrioventricular blocks. So you'll see, your second degree type 1 and 2, possibly third degree AV blocks as a result of the damage that the organism has done to the cardiac cells. We can also see mega esophagus. So the organism seems to like to get into smooth muscle as well as cardiac muscle. The patients with mega esophagus, they'll commonly have this condition called achalasia, where the lower esophageal sphincter doesn't relax. So then it becomes really hard for the patient to swallow anything. And then further progression, you end up with possibly patients having strokes. So that's the clinical presentation for this. Going back to the life cycle. So back in the early stages where you had trypomastigotes in the bloodstream, this is going all the way back to the acute phase. you have trypomastogotes in the blood, and the way that this life cycle is completed is you have another kissing bug comes along, takes a bite, takes a blood meal from the infected person with active trypomastogotes in the bloodstream, and the kissing bug takes up the parasite into its body, and the trypomastogotes move into the bug's midgut, where they turn into the stage we call the epimastogote. At that stage, they are replicating once again, so they go through another stage of binary fission within the bug midgut, and then they move further down into the bug, into the hindguts. So basically, it would be like the large intestine of the human would be, I guess, the analogy there. So in the bug hindgut, the parasite regrows its tail, and you now have metacyclic trypomastogotes, which is the stage that's going to eventually pass from the stool to another host. So that's the life cycle, right? And then we have the acute phase of the infection. We have the chronic stage of the infection. And if we look at, well, what can we do as healthcare providers to prevent this? So the best prevention for any vector-borne disease is going to be avoidance of the vector. In this case, the kissing bug. So the best way to avoid this bug bite is going to be to not sleep on the floor. That would be one thing that you can do. Sleep in a hammock, get off the floor. If there's no other choice other than sleeping on the floor, then you're going to need some insect repellent on yourself, especially on your face, which is not the ideal way to drop off to sleep with insect repellent on your face. But if you're in an endemic area, and again, you're sleeping on the ground, and you're in a place like you're in a village hut or someplace like that where there's lots of cracks and crevices and things like that, then you're definitely you're at risk of getting these bug bites. Now, if you're in South America at a 5-star hotel, the chances of having these bugs come out is next to none, because the nicer hotels aren't going to have all the hidey holes that the insect likes to take advantage of.
Wow.
In the acute phase of the infection, well, so this is like practically any disease where it's going to be easier to treat the disease and prevent a pathology. The sooner we start treatment, the longer this disease persists and continues to inflict more damage on the cardiac muscle and the smooth muscle of the GI tract, the more sort of permanent damage we're going to end up with, and your treatment options become more and more radical. So again, in the early stages, if we catch this early enough, we can come in with antiparasitic drugs, right? So the antiparasitic drugs, there's 2 of them that I found in my tropical medicine texts. So one of them is benznidazole, and the other one is nifurtimox. So those would be your drugs of choice if you can confirm infection with this organism, ideally in the acute phase. If it goes into the chronic phase and you're able to do an IgG test for Trypanosoma cruzi, then you might have these 2 drugs as an option. If there has been more damage done to the body farther along in the chronic stage, then you have other options all the way up to cardiac transplants in very severe cases of this disease.
Actually, Jason, I remember you and I were stationed in 3rd Special Forces Group, and we invaded Haiti. And when we first got there, I don't know how it was with when you got there, it was 6 months after I did, but we were living in the hangar. We had nothing. There was no nets. We were literally laying on the ground, sleeping until things settled down a bit. And then we went in country a bit. How dangerous was that? Were we completely at risk?
That's a really good question. I don't know if Haiti, the island of Hispaniola, so Haiti and Dominican Republic, I don't know if Chagas disease is endemic there. I would have to check my references for that. But yeah, if you're sleeping on the ground in a place like that, so Haiti is I call it subtropical, although it certainly felt tropical while we were there. Yeah, if the bug was there, then you would have definitely been at risk. The way you guys were sleeping there, you guys were on the I think the first push into Haiti. I came in 6 months later, and we weren't sleeping on the ground, but we were sleeping on cots in we were kind of up the hill from Port-au-Prince in this. It's kind of the military medical school of the island called Camp D application. So we were up there sleeping on cots, and I don't recall seeing this particular bug, but we certainly had plenty of tarantulas going around, which fortunately are not disease vectors and are pretty gentle arachnids for the most part.
So let's look at this as a medic, as a 18 Delta for yourself, and a remote medic, remote nurse, a doc who's listening to this and needs to know how do you know someone has, how is their patient going to present with Chagas, and how would they know when to give the benznidazole? How do they know that this is the pathway of, or how do they know that this is the ailment that their casualty has?
Well, I would say there are two ways that we could diagnose the acute phase of this. The simplest method, so if we have if we don't have microscopy, basically, if we don't have microscopy, then it's going to be a clinical diagnosis. So if you have, number one, you're in the endemic area. So if we're in Australia or someplace that doesn't have this disease, then the chances of this are essentially zero. But if we're in an endemic area, we might formulate a clinical diagnosis. So we're in the endemic area. The patient was basically at risk of getting this bug bite. So they were sleeping in typically, you see these in like adobe huts and things like that. So kind of a, primitive sleeping structure, if you will. So they were sleeping in something like that, and in the endemic area, and then they come to you complaining of fever and malaise. And if they have a chagoma, or the Romagna sign, so if they have unilateral, so it's called unilateral periorbital swelling. If you have sort of that constellation of risk factors and clinical presentations, I would say that's enough to make a clinical diagnosis of acute stage Chagas disease. From there, right, because so these antiparasitic drugs are not easy on the system, if you will. So you do have some significant side effects with these. So these are not drugs I would want to just use in a setting like this. So what I would want to do with that patient where I've come up with a clinical diagnosis is I want to either get a microscope or get that patient to a location where we can do microscopy. So if we have to put them in a truck and drive, 10 hours to the capital of the country and, get a microscopy test to confirm this, that would be my preferred choice. Cause the antiparasitic drugs are not, they're not harmless drugs to give. So that would be my approach in a setting like that. If microscopy was not an option, but I had formed a clinical diagnosis, then as a medic, I would be on the phone or, the sat phone or whatever with my medical control and explain the situation. Like, hey, I've made a clinical diagnosis of Chagas disease based on X, Y, and Z. I would like to move forward with an antiparasitic drug therapy. What do you think? And sort of, this would be one of those cases where I would like to get permission to give a drug that has a lot of side effects before giving it. So that would be my approach if I don't have microscopy. And then of course, if there is microscopy, then we'll go ahead and again I would just do a thin blood smear just like we would for malaria, stain it, and then we examine that under microscopy, oil immersion. And we're looking for the characteristic trypanosomes within the blood.
And what about an RDT?
That's a very good question. I don't know if there is an RDT for this. I wouldn't be surprised if there is one.
And it says one of the symptoms is enlarged spleen, enlarged liver. We have ultrasound everywhere. Is that something that we could use to help diagnose this?
Absolutely. We want to bring every clinical tool we have to bear with something like this. Certainly it's, anytime we're formulating a clinical diagnosis, it's just, we have a 500 piece jigsaw puzzle and we want to line up as many pieces as we can. And once we have a clear enough picture as to the diagnosis, then that's our clinical diagnosis, and then we can move forward with our clinical decision making process. Obviously, we're not going to scan the abdomen with an ultrasound and see hepatosplenomegaly and immediately know what disease that is, but it's just part of the puzzle.
And I'm taken aback that you didn't say malaria because they present with a fever. So having a malaria test as well.
Absolutely. Yeah. You definitely want your malaria RDTs or better yet, like microscopy in these kind of settings. So another way that we can diagnose this perhaps is we end up with a diagnosis of exclusion. So let's say we're in Latin America or Southern US now. We're in Latin America, Southern US, and we've got, we've run a malaria test, which was negative. We have a history of insect bites, and we're not sure, were these all mosquitoes or were they kissing bugs or sandflies or whatever. But if we can start ruling things out like leishmaniasis, sandfly fever, malaria, arboviruses, then what we do is we whittle down the differential into one or two or three things, and then we take that with all the information that we've gathered, and then we have to make a clinical decision and or turf that decision making out to an infectious disease doc or a medical controller, top cover or whatnot.
And this is now spread to continental U.S. Is that right?
It has. Yeah, very, very recently in the news, we've seen a couple things now from, south of the equator here in the Americas, inch forward, and we're seeing a couple things now in southern U.S. One of them is this, so Trypanosoma cruzi, and the other one is the New World screwworm has also moved its way north. So yeah, things are changing.
So this is a risk of death. So is this a cardiovascular death? And how many people die each year?
I don't have a number on the number of deaths per year. So to my understanding, Chagas disease is more of a disease of morbidity than mortality. So you just end up with people that are very ill later in life if it gets to the chronic stage. So now they've got mega esophagus, they have trouble eating and drinking and swallowing. They're running with atrioventricular blocks, right? So their quality of life is diminished, and eventually it can be fatal. But certainly there's going to be a very high number of people with morbidity from this disease.
So as a wrap up, what's your take home message for this disease?
So we'll get to the take home here in a second. Another thing I should mention certainly here is that there are other ways to get this disease. So the other ways this is commonly transmitted, or maybe less commonly, but certainly known transmission pathways are through blood transfusion. Right. So if you have a person with acute phase trypanosomiasis and they donate blood and it's donated to someone else, well, now you have trypomastogotes in the donor, or I'm sorry, in the person that received the blood. Right. So that is one way that you can transmit this. So this just adds another layer to screening blood prior to donating it to patients that need blood. So you can get it through blood transfusion. You can get it through organ transplants. It can be passed transplacentally. And another way that this is transmitted, which is quite rare, but something to think about if you're in an endemic area. Let's say the bug was out crawling around in a field of sugarcane. The sugarcane gets harvested, and the cane gets sort of mashed down for its the cane juice, and the bug is in there, and the bug gets mashed up. If it had epimastogotes or metacyclic trypomastogotes, that can end up in the cane juice, and that has been seen as a transmission pathway as well. So just something to consider if you're in that endemic area.
So this bug, it does not just stay in places where humans are. It's not staying in your hut or in your village. This can be out in a patrol base.
Yeah, absolutely.
Wow. And here we are sleeping on the ground in a patrol base, doing our job as SF guys. And we're thinking of malaria, rightly so. And not once did I ever think about this.
No, I don't know. I haven't been to Latin America per se. I've been to Haiti, which is as close as I've been there. But yeah, I would hope that medical providers, especially 18 Delta type medics, SF medics, that are deploying to that part of the world and they're out, running patrol bases and sleeping on the ground and those kinds of things. Beyond all the other things that you can get from sleeping on the ground in the jungle, I hope that they are taking some consideration on this organism as well.
Jason, what would be the take-home message? What does the medic on the ground need to know about Chagas?
So the medic on the ground, when they're thinking about Chagas disease, again, where are we going to catch this? We're going to catch it primarily from being in and sleeping in areas where it's endemic. So that's going to be most of South America, Central America, getting up into Mexico on the very southern border of the U.S. So that's where the insect vector has, where it is endemic. Also, if you're in that part of the world receiving an organ transplant, getting a blood transfusion, or anything along those lines, we want to make sure that both the organs and the blood have been screened for Chagas disease in addition to other bloodborne diseases.
And now this includes Texas as well.
Yeah, I believe Texas is on the list now, and Southern California. I think those are the two places where we've seen this now.
Well, Jason, thanks for a deep dive into this, something that I hadn't thought much about before studying tropical diseases. And due to global warming, this is now becoming a problem in the U.S. as well.
That's right. Things are changing. We have climate change. We have more and more people traveling. We have, the lines of demarcation where you find different disease vectors. Those are constantly changing. So, yeah, the best thing to do is just keep up with the literature and just stay apprised of what's out there.
Well, I appreciate your deep dive. And every 3 months, we like to dedicate one of our episodes to tropical diseases and having you jump into the latest and the greatest. Do you have any idea of what you plan to do in 3 months?
In 3 months, that's a very good question. 3 months feels like a very long ways. From here, I will be engaged primarily with, you and I both, getting the 3rd edition Quorum field guide off the ground. And, there's lots of things to pick from with tropical diseases. Maybe we'll have that discussion on the New World screwworm, Cochlemia hominivorax, unless something else comes up in the news or in the medical literature.
Well, thanks for your input. Thanks for taking an hour to chat with us about this, and have a lovely week, mate.
Thanks. You too, Aebhric.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.